Hello and welcome to DentalXP.com. I'm Dr. Maurice Salama, and today I'm going to be taking you through a rather interesting case of severely resorbed and mobile dentition in the anterior region that has been retained for many years and is now failing and needs to be replaced. You can notice the severity of the resorption that had taken place over 5 decades, and we're going to attempt to replace these teeth in a rather atraumatic and advanced manner. We're going to go ahead and perform sulcular incisions and release the junctional epithelium and connective tissue fibers. And obviously, very simple to perform, very atraumatic extraction in this case with straight forceps. The teeth are rotated out and you can see the severity of the resorption, which had led to the mobility in this patient's case, which was her chief complaint. The desire to keep the foundation and structure of the soft tissues and of course the aesthetics was of utmost importance, so simplified extraction and tooth replacement with implants is extremely important. Again, rotating and releasing the fibers slowly allows for minimal damage and tearing of those connective tissue and junctional epithelial fibers within the sulcus and within the area around the bone and soft tissue. You can see us here measuring the thickness of the gingival tissues, which is again extremely important when evaluating extraction sites. One of the important aspects is to do this with cone beam imaging to evaluate the thickness of bone as well, and then the thickness of tissue. We're then going to materialize SurgiGuide to actually place our implants according to the digital treatment plan. And being able to do that utilizing a surgical guide minimizes the risk of us placing the implants in the areas which would not manifest the best restorative plan. So surgical guides, when I think in multiple tooth replacement situations, certainly makes this type of procedure very precise and limits the amount of potential downside risk with poor implant placement, placement with too much angulation, or of course placing the implants too close together. The patient had desired to have individual teeth in the final restoration and she did not want a bridge, so we were going to attempt to place 4 implants to replace the 4 missing teeth. We're going to be utilizing in this case Zimmer tapered screw vent implants. We're going to be utilizing the 3.3 millimeter implants in the lateral incisor position and the 4.1 millimeter Zimmered trabecular metal implants in the area of the central incisors. And our attempt is to be able to perform this surgery with immediate temporization. So the placement of the drills through the guides allows for very precise control of the 3-dimensional aspect of the implant direction, both buccolingual, mesial-distal, and of course apical coronal. Very, very precise drilling sequence, and again very important to be able to use copious irrigation with sterile saline or sterile water. And we like to cool that water to make sure that we can underheat the sites, making sure that there's no overheating of the bone during the drilling sequence. This placement of the guide pins to further evaluate the direction of the implants utilizing a suck-down matrix, and that verifies that the implants are placed precisely where the future restoration requires it. That means that the screw access channels will be inside the cingulum access. The 3.3 millimeter straight tapered screw vent implant is now inserted utilizing 30, then 40 newtons of initial torque insertion. We then go to the hand ratchet and we will hand tighten the implant down well beyond 45 newton centimeters. Now placing the other lateral incisor, again placing this implant down to very high initial torque insertion values, which is something that we look for whenever considering immediate implant placement and temporization. The trabecular metal implant, made of tantalum, is something that is fairly new to the market. It increases the porosity of the midsection of this implant by approximately 80%, and it's made to actually replicate the structure of cancellous bone. You can see the micro grooves on the top have also been a new addition to this implant design, and we added plasma-rich growth factors, or PRGF, to the body of the implant, and you can see the amount of hand tightening required to insert this implant through this osteotomy. Again, the trabecular metal implant inserted, you can see how it actually absorbs. You can see here putting it into the site and showing you how the blood is absorbed by the porosity of the tantalum material. You can see how the blood actually invades the pore size here, which is approximately on average 440 microns in size of the trabecular metal midsection of the implant. Again, the overlay of the final bridge, again to verify that the direction of the implants is precisely where we had planned it, and something that my partner David Garber once published in an article where he said that implants should be prosthetically driven or restoratively driven implant placement. Whenever possible, we like to place implants towards the lingual, 1 to 2 millimeters away from the labial plate. And this also assures the potential of doing a screw retained versus a cementable restoration. Here you can see that there's a micro gap between the body of the implant and the labial wall. Again, the thickness of soft tissue approximately 2 millimeters. This is an ideal situation. And we'll now be able to graft this space, not just relying on the blood clot. And we're going to do this, again, planning for immediate temporization, utilizing the Zimmer HLA contour abutment series. This is a permanent abutment. The concept of one abutment, one time can be utilized here. So we're going to insert the straight contour abutments on all 4 implants the day of surgery, just with hand tightening of the hex driver. We're then going to utilize bone grafting material. This is PRGF and Puros cortical cancellous mixture into the gap, 1 to 2 millimeter gap between the body of the implant and the labial plate. This can be introduced utilizing this bird beak bone condenser from Devamed, an excellent bone condenser that I like to utilize to get into small spaces. It has a round beak, and it allows me to actually pack the bone into those spaces. Now, the HLA contour family also allows us to utilize the temp-based caps that fit precisely onto the margins of these abutments. You can see that we made small little holes in the abutments so that they will retain the acrylic when we reline the restoration. And you can see that this can be done, again, utilizing the restorative guide. We simply paint the monomer of the acrylic the day of surgery into the guide that's supported by the vacuform matrix. And this is utilized basically to pick up these temp-based caps that have sealed the margin. So we're just going to place a little bit of acrylic into the small little prepared round burr holes of the temp-based caps that adds retention and allows us to pick up the caps utilizing the vacuform matrix and the temporary within that matrix. This is a rather easy way to perform immediate temporization. You can see the caps are now picked up off of the implants. Not too much material is needed. And now the rest of this can be performed outside of the mouth in terms of backfilling to the margin of the temp-based caps. In order to make sure that the screw access channels of the HLA contour abutments are sealed, we like to utilize Teflon tape or plumber's tape. This allows us to feed this into the screw access to protect the screw access from the cement on the day of surgery. So just a very simple tool that we like to use here in the office, a plumber's tape that allows us to easily protect the screw access channels. I know many people utilize other materials, but this seems to work quite well for us in our office. And I know many of you may also be interested in using it. Very inexpensive and very easy to use. Now we're going to go ahead and use a barricade material. This is a periodontal pack dressing material that's light cured. We're going to pack that into a syringe on the day of surgery, and this allows us now, on top of the plumber's tape that protects the screw, and we can syringe this barricade material on top of the Teflon tape and then very simply light cure it. And this makes certain that no cement or reline material can enter into the screw access channel. Very simple to place and introduce, and makes it very, very easy for us to remove it if needed in the future. So very inexpensive, something that is very easy for us to utilize the day of surgery. And you can see now, once the temporary has been reshaped and we have filled down to the levels of the temp base caps where the margin of the restoration meets the margin of the abutments, we're now going to simply test that to make sure it seats all the way, that we have a path of draw. We then evaluate the occlusion, and very often for us, we will not allow any contact, whether it be in centric or in excursive movements. Certainly in incisal guidance, we want no contact from the day of surgery until approximately 2 to 3 months after the implants have been inserted. And that's something that we do just to protect our implants. We only want them to support the temporary restoration, but not to be in functional occlusal loading of any kind. Some people do occlusally load these restorations the day of surgery, and certainly I believe it's possible, but I think you increase the risk of premature failure, especially with the fact that incisal guidance or off-axis forces may be unusually high. Right before cementation, I will then further introduce PRGF, or plasma-rich and growth factor solution, into the sulcular environment, and we will cement the bridge with a very, very light mixture of temp bond and antibiotic paste. And you can see we place little vent holes in the lingual axis to allow that cement not to be driven subgingivally, but to be able to come out through the top and the cingulum axis of the temporary restoration. You can see how this looked approximately 4 weeks later, and you can see the radiograph at approximately 8 weeks that suggests excellent osseointegration and certainly ideal outcome for this individual. I'd like to thank you once again for joining us at dentalxp.com, and I hope that you have found this video interesting on some of the new techniques and technologies in implant dentistry.